Think curious and creative. If you've got a good relationship with the patient on the other side, ask them to put the camera on the floor and stand in front of it so you can really see those ankles. And you sometimes get a better view of the ankles there than you ever would in your actual practice.
I am not advocating for exclusive telehealth provision of care, but I think that if we can blend it into our usual care, the results are fantastic. And there's actually a growing literature to support that as well.
That was Dr. Brent Ohata and Dr. Tommy Gerschman. They're our guests on this special episode of Around the Rheum. We're going to be talking about telehealth in rheumatology. Hi everyone, welcome back to Around the Rheum. I'm Daniel Ennis. Before we get to our guests, I want to announce some upcoming episodes on a whole bunch of interesting topics, including psoriatic arthritis, Sjogren's disease, large vessel vasculitis, myositis, autoinflammatory diseases, IgG4-related diseases. If you have questions you'd like answered by the experts, please contact us through the CRA Twitter account, CRA_SCR_Rheum, or by email at info@rheum.ca. Now on to our guests. Dr. Brent Ohata is an adult rheumatologist and clinical assistant professor in the UBC Division of Rheumatology. He is the co-chair of the CRA's Telehealth Working Group. He has a clinical focus on Indigenous health and health equity and has been a longtime advocate for integrating telehealth to improve access to rheumatologic care in rural BC. He won the 2017 Innovation Award in the UBC Division of Rheumatology for his work in the field. Dr. Tommy Gerschman is a community-based pediatric rheumatologist and sports medicine specialist. Dr. Gerschman has assisted with the BC Ministry of Health's digital health strategy and associated policies. He has extensive leadership experience, having worked on various Doctors of BC committees before becoming a member of its board. Following this, he served as the Specialist of BC President until 2020. He is currently the co-chair of a community-based specialists working group. Both have played important roles in advocating for telehealth in rheumatology care. Hello, Brent and Tommy. Welcome to the show.
Hi, Daniel.
Hi, Daniel.
It's great to have you both here. And I want to start off by establishing where telehealth was even a short time ago. So, Brent, you've been doing telehealth since 2015. It's hard to remember a time before COVID, but what was telehealth like in the olden days?
That's a great question, Daniel. I think telehealth was very much a niche specialty back, in 2015 when I became involved in this. It was being used typically, at least in British Columbia, to connect one hospital to another hospital. It was very sort of bulky and cumbersome. And what we were seeing at that time was, rapid innovation in the private sphere, with things like FaceTime and other sort of programs. And we in healthcare were far behind. However, with the COVID epidemic, I think this is one of the silver linings. There's been a huge adoption of telehealth as a consequence of this.
And Tommy, when did you start using telemedicine and why did it appeal to you in particular?
Yeah, I think, before the pandemic, I had a couple of experiences and we used sort of Skype. I was collaborating with Dr. Michelle Teo on a couple shared patients where, we sort of fired it up and gave it a try and it was definitely clunky and, very different. And it was not necessarily provider to patient directly. It was always somebody else there kind of involved and be another rheumatologist or, I think family doctor or so on.
So COVID kind of became the push for us to actually develop these technologies more quickly to become clinically useful when we couldn't bring people safely into clinic, I suppose.
Most definitely.
Yeah. So let's talk about how telehealth has been rolled out in Canada and how it's being utilized. The CRA has certainly been taking an active role in this, but I just want to give a little bit of background and set the table for listeners. So in December 2020, the CRA Telehealth Committee published their physician survey results on telehealth use in Canada, and that would have been kind of, a few months for sure into the pandemic, but still a few years ago. They documented that 36% of appointments were still in person, 45% by phone, and 19% by video. 30% of physicians were seeing the majority of new consults by telehealth, yet only about a quarter of the doctors who responded to the survey said they were either comfortable or very comfortable using telehealth. And Brent, maybe I'll direct this to you. What do you make of those numbers?
Well, Daniel, I think that we pivoted towards telehealth by necessity as a consequence of the COVID-19 pandemic. It would have been lovely if we had been able to pivot in a more organized fashion, but like everything during COVID-19, I think we made do with what we had and did the best that we could under the circumstances. I think there's still quite a lot of people that see patients by telephone exclusively. For me, I think one of the benefits of telehealth is, being able to do a physical exam by video, and I think it's really the CRA's job to try to improve the standard of care that we're providing by telehealth to ensure that we really are doing the best we can to obtain a physical exam with the limitations we have using telehealth.
And I know that you've spoken and lectured about this pretty extensively, so you're certainly working to that end. 2 years into the pandemic, what progress, Tommy, maybe what do you see as the progress we've made in terms of using telehealth?
Yeah, I mean, if anything, this has been a real trial by fire, and I think people are variably comfortable with different technologies and things like that. I think my own experience when it was sort of, okay, next week I got to call all my patients and shift them to video. I mean, I still remember those first couple of days, and I remember going through my patient list and thinking like, oh, that probably won't work. Oh, that probably won't work through telehealth. And in the end, I think I sort of said, okay, well, let's just give it a try and see what happens. And the nice thing at the beginning, at least what I experienced, was, everybody was, trying to help each other out, right? Like everybody, the patients were happy to be seen. Everybody was patient and understanding of the situation. And I think that allowed me to sort of be curious and say, okay, well, maybe we can get you to stand up and walk around and, oh, look at that. I could definitely see that effusion of your knee. That's quite obvious. And I remember picking up my first hip limited range of motion on a patient thinking, oh, that actually was pretty obvious. And of course, I confirmed it in person later. So for me, I think, by using, we learned a lot. And then I think also by sharing. And I think Brent and the CRA has really taken a leadership role at this. I mean, I remember watching Brent's intro webinar, which I'm sure a lot of people watched, that had some really practical tips that improved my confidence in going forward. And since then, there's been lots more dialogue and discussions that I think have moved the needle forward in terms of quality as well.
Right. And so you kind of wear multiple hats. And as I mentioned before, you were working as head of the specialists at BC. I'm curious about what was happening behind the scenes to encourage rheumatologists to embrace telehealth, if you can speak to that at all.
Yeah, for sure. I think, at the beginning of the pandemic, exactly 2 years ago, it was, I remember the first week of March, there were these thoughts and discussions about, where are things spreading? What are we going to have to shift? What's happening in doctors' waiting rooms, which, I mean, classically are overflowing with people and coughing and so on. And we started thinking about how do we shift people to telehealth and what would that mean? And I, along with some of the other leaders at Doctors of BC, and I'm speaking about British Columbia's experience, talked about what would it take to sort of enable people to sort of jump into this. And we thought, number one, you have to be able to bill appropriately for it. And it was felt that, if you're delivering quality care, you should be paid the same. I think that was pretty early on. We felt equivalency anyways. And then the other thing was you need to have the technology there to actually do it. And what were we going to use? And Zoom, was nowhere near where it is today. Right. But so we actually wrote to the BC Medical Services Commission to try to change some of the language in our physician master agreement to enable sort of full-fledged, telemedicine. And at the time, it was like, we just need to keep providing care. So whatever kind of works. And some privacy things were limited, and there was all these discussions about what's going to be the most secure or not, what data goes through the US. So there was a lot of talk behind the background, and I think I'm pretty proud in BC that fairly quickly adopted a just get healthcare done approach, and we're still in that environment where you can use video or telephone to provide most types of visits.
And that was I work in BC as well. All three of us do, and that was kind of the experience from my side, which is don't worry about the finances and the businessy aspect of your job. Just keep delivering good care, and doctors of BC and specialists of BC and the government will they will sort it out. And so I know there was lots going on behind the scenes.
Yeah, and I think part of why we sort of jumped in there so fast, or what I thought was, it's going to be hard enough for people to trust this new technology and even just the workflows. And I mean, how to tell patients, how to prepare patients, how to send them a link, whatever was going to be enough. So let's not worry about the billing side of things. And we tried to work with as many different vendors as possible to try to get not necessarily a one-size-fits-all solution, but to have multiple options for technology, some that were integrated directly to your EMR and others less so.
So now that we've kind of talked about kind of where things began and have progressed through the pandemic, maybe we can turn a little bit to the patient side of things. So Brent, you've been doing this for quite some time and paying pretty close attention to the literature, I'm sure. What's your impression from your personal experience and literature? How do patients actually feel about the use of telemedicine?
Great question, Daniel. So there's quite a lot of literature that's come out in the past year or two about acceptability of virtual care in the rheumatology world, both acceptability for clinicians as well as acceptability for patients. And consistently, there's been very high patient acceptability for telehealth. I think probably the most promising thing is the fact that we may be able to use virtual care to improve access to a lot of patient populations that otherwise have been neglected by our current healthcare system. Patients who live in rural areas, patients who struggle with many challenges in accessing healthcare, either because of social determinants of health or whatnot. It is, however, a double-edged sword, so to speak, which is to say that on the one hand, we may be able to use virtual care to improve access to many marginalized populations. On the other hand, some surveys have shown that patients who typically are marginalized, Black, Indigenous, people of color, are often the most uncomfortable with telehealth, as well as those who typically don't have as many devices, don't feel as technologically comfortable.
We'll be right back to Around the Rheum after this brief message from the CRA. Did you know that membership with the Canadian Rheumatology Association offers outstanding value through knowledge sharing, accredited educational offerings, advocacy, and research support? Members receive access to free webinars, programs, and discounts to events such as the CRA Review Course and annual scientific meeting. Members also receive complimentary subscriptions to the Journal of Rheumatology and the Journal of the Canadian Rheumatology Association. Trainees can join for free and are eligible for educational and training opportunities, travel bursaries, and much more. These are just some of the many benefits of joining the Canadian Rheumatology Association. And if you're an existing member, spread the word to rheumatology colleagues who haven't joined yet. They'll thank you for it. For more information, please visit our website at
www.rheum.ca. At the CRA conference in 2021, you both were on opposing sides on the great debate. So Tommy, you argued for telemedicine. Brent, you argued you had to take the stance of arguing against it. And that argument was the one that really struck me, that the rise of telemedicine was good for certain patients, like difficulty with mobility, getting into clinic, people who are further away or outside of urban settings or, interior BC here on the West Coast here. But that it exacerbates inequities in care between tech savvy and either not so savvy or lack of access. And how do we actually get past that? Like, have we kind of helped patients bridge that gap? Have we met them where they are, or is that still a major gap in care?
I'll tell you something, Daniel. So I have the pleasure of actually servicing some extremely remote communities in British Columbia, some of which are hours down dirt roads. And I think the question we need to be asking ourselves is not what are the limitations of virtual care, but what can we do with this? Like, what can we do? Like, what are the boundaries we can push, both for our physical exam, but then also for accessing people such as this? So, in truth, in some of these communities that I service, most patients do not have internet in their house. There is like one sort of radio cell phone tower that's able to transmit telehealth or transmit internet. And the workaround that we have is that, we have the patients come into the nursing station on reserve. It's an Indigenous community. And it works out great. I mean, they're able to walk, 10 or 15 minutes to the local health clinic where they have, significant trust and comfort that's been built up over the years, and are able to see me, who, typically practices a 13-hour drive away from these communities. So you think about the previous model of care of asking patients, for example, with active rheumatoid arthritis to come down every 3 months for a 15-minute visit to see me. You think about the amount of money and the dangerous roads and time off from work, and it just makes so much more sense to be doing things this way. I'm not advocating for exclusive telehealth provision of care, but I think that if we can blend it into our usual care, the results are fantastic, and there's actually a growing literature to support that as well.
So it seems like please go ahead, Tommy.
Yeah, I was going to say that. I don't think it has to be a one-size-fits-all solution. I think this is a tool that we've all, including our patients, learned to use, and many of us become more comfortable to use. So it's another tool. And, I think that we should be aware of where the limitations are and where the potential worsening of marginalized populations might be, so that we can make sure that we're making space for them as well to sort of compensate. Because if all of a sudden, you can see maybe more people virtually and that you have more room in your office, maybe it makes it easier for those who otherwise have challenges getting there. And I think the other thing, hopefully that this pandemic is over or almost over, and so on. So we'll have more choice. We'll be able to, I think, design it to what suits our needs and our patients' needs versus what the public health needs of the moment are.
Mm-hmm. And two comments to follow up on that is that in addition to patients being accepting of telehealth, there also I see evolving literature that there are similar outcomes in terms of stable and new rheumatoid arthritis and other types of arthropathies where, I think one thing that I worried about when I started using it is that the lower fidelity of just seeing someone by video conference or talking to them over the phone is going to lead me to make decisions that will influence the course of someone's arthritis. So that was my fear. And I guess the evolving literature that's suggesting that that's not necessarily true is helpful. I still worry about it though. Should I?
Well, I think as you point out, Daniel, that the literature is developing. I think the two papers that I typically highlight with regards to safety of virtual care. One of them is the Regina Taylor-Jever paper from Saskatchewan, where she showed that patients that were followed with rheumatoid arthritis for the course of a year by telehealth had essentially similar outcomes to patients who were seen in person. There's also an interesting paper that came out in summer of 2021 from a group in Italy, someone named Piga, where they had patients with ankylosing spondylitis, rheumatoid arthritis, psoriatic arthritis, and lupus. They were seen by a video by clinicians and then followed up in person 2 weeks later. And they wanted to see whether or not there was any difference in terms of decisions to escalate care, de-escalate care, or maintain the current course. And in point of fact, there was virtually no difference between the decisions to, the clinical decisions that were made by telehealth when patients were seen in person. I think the in-person assessments basically verified that the clinical decisions we make by telehealth are often the correct ones.
Mm-hmm. The second item that I wanted to point to before we move on is that the CMA did a survey in 2020 that included kind of patient perspective on the use of telemedicine. And even though most patients seem satisfied with the use of telemedicine, by preference, most patients seem to want an initial in-person first contact with doctors. And I wonder what you guys think about that.
Well, I think that a lot's changed since 2020. So, I mean, it would be interesting to see where that goes. And in fact, I'm sure it actually, like a pendulum, I'm sure it peaked the other way. Like, I think people probably would have preferred virtual at one point, and probably it's come back a little bit now. I think, again, it's different personal preferences, and people have now done it and used it, or had relatives or friends who've done it and are more comfortable. So I think it's a very quickly shifting landscape. I think at the end of the day, the patient-physician relationship is about building trust. And I think there is certainly something to be said about looking someone in the eye and sharing the same space with them, physical space with them. I think it does have an edge over virtual space. But I think that, with video and, your demeanor, your talk, your pace, all those things, how you set things up, I think we can also create those, appropriate relationships as well that are strong and appreciated.
I completely agree with Tommy's comments about the interpersonal dimension that occurs during an in-person versus a virtual initial visit. I have two other comments, however. One comment would center around the patient's environment. So I think if you are a patient who lives 15 minutes away from my office, it absolutely makes sense to have initial consults, in person whenever feasible with the COVID-19 pandemic. However, I also, as I mentioned before, see a lot of patients from all corners of the province very far away from any rheumatologists. And I think in those cases, doing initial consults is much preferable to having them wait for months and months and months to be able to see someone in person, particularly if they're seeing by traveling clinic that goes up to their community sporadically. However, I will as a second point just emphasize that this is a very important question within the literature. We don't know about the diagnostic accuracy provided by initial consults in rheumatology virtually.
I think the other, rheumatology, one of the things I enjoy most about rheumatology is the importance of physical exam and physical exam findings. But I think it still holds true that, history trumps physical most of the time. And I think that's why, virtual is so viable. And in fact, that's why telephone, has a role to play as well. I think, Brent and I are both strong believers in the video component, but, I think at the end of the day, we know that history will drive most, of your decision making, at least your pretest probabilities and all of that sort of thing. So, I think that's one of the reasons why maybe some of these outcomes where decisions aren't necessarily different based on virtual versus in person 2 weeks later.
Yeah, so it certainly seems like you both made a case that it's a tool in the tool belt. It's not to replace physical exam or in-person assessment. it's to complement it, and that we need to have some agility in terms of deciding on a case-by-case, patient-by-patient basis who's an appropriate candidate to do video, telephone, or who needs to come in. So I think you both made strong cases for that.
The analogy I like to make, Daniel, virtual care is just like a stethoscope. I don't think you would ever plan a cardiac surgery based on cardiac auscultation with your stethoscope, but it's a tool that we all use, and it's got its role in medicine, and it's our job to figure out how to use virtual care in a safe and effective way.
One thing I wanted to add actually was one of the challenges I came across when virtual care was just getting going. The CMA had come out with their virtual care playbook. The Royal College had looked at that and essentially said, we think this sounds pretty good. We'll flag on top of that or jump on top of that as well. And in there, it said that musculoskeletal care is inappropriate for virtual. And I think that took me aback because, I knew that was not necessarily true. I think we've come a longer way from that. I think the CMA has heard from other organizations like the CRA that there is a role, an evidence base for rheumatology and musculoskeletal care in general to be done virtually too. So I think we've come a long way from that sort of like, oh, you can't do musculoskeletal stuff over video.
And to follow up on that, so we have come a long way, and I'm wondering, Tommy, if you can comment on where you kind of expect things to go in the next 5-10 years, if there's going to be any major changes to the way we practice, or have we kind of plateaued in terms of what to expect?
Yeah, that's a great question. I mean, in terms of the fees, I think that the position statement the Canadian Rheumatology Association came out with was really good. And in terms of looking at that, I think fees should be equal in terms of mode of delivery of care. If the quality of care is the same, then the mode shouldn't matter. I think each province kind of entered into telehealth in slightly different ways, and I think is coming out in different ways. And I think we need to listen to our colleagues across the country and help them advocate to ensure that it's still a tool that they can use for all those reasons we just talked about. I think that as we come out of the pandemic, most governments are going to look at telehealth, and I think they're going to look at things that have driven up utilization. Telephone has, I think, driven up utilization just because it tends to be a little bit faster. I think virtual walk-in clinics that have popped up across the country, more so in primary care, have also played a role or are playing a role. So I think there's going to be a push to try to get a sense of where things are going and how to control spending, as the government always tries to do. And I try to indicate that we have to treat different specialties differently. And certainly I can't speak on behalf of primary care or orthopedics or whatever. And I try to speak about rheumatology, and I think that there is an important role for it to play in rheumatology. I think that we'll know better with time different workflows to more efficiently integrate telehealth into our practices. I think as we all sort of start opening up our clinics fully, people will start thinking, am I going to have every third patient be, telehealth? Am I going to have a telehealth afternoon? Am I going to, what am I going to do to make that workflow? And I think that will be something for us to all learn to sort of just be more efficient as well.
Yeah, I'm kind of interested in the science fiction future of what do offices look like now that we have an option of not always seeing people in person, which to me also means not always physically being in the office. Where do I practice now, and what does that look like may shift over time. So Brent, I'd love to hear, because I've seen your lecture on this, but I'd love to give listeners maybe your top few tips for success when you're doing telehealth.
Sure. Well, again, my top few tips really center around video telehealth. I think the number one tip is do try to do video as opposed to telephone. You gain so much more clinical data, and it allows you to provide much more targeted, precise, clinical care. I understand that it's challenging, and I understand that there is a learning curve. What I would strongly recommend is that you don't take the burden on completely by yourself. There's a huge amount that your office staff can do to prepare the patients in advance, either from sending out emails, describing appropriate clothing and lighting and appropriate settings. I think we've all had patients connect to us, while they're, a passenger in a driving car, which is not very appropriate. And then beyond that, I think there are very many resources at this juncture available for creative ways to perform the MSK physical exam. I think there's an excellent paper by the Mayo Clinic on this. Bone and Joint Canada has excellent resources as well. I think if you want the most comprehensive body of information for how to set up a successful telehealth encounter, I would probably go to the Bone and Joint Canada website. They've got everything there.
That's great. And Tommy, maybe the last word to you, and any extra tips that you'd add on.
I'm lucky. I get to work with kids all day, and they are definitely, often a little more limber, depending on how well we're treating their arthritis, I guess. But I think I'm fortunate that there's usually a second person there with them that can sort of take control of the camera, and we can be a little bit more mobile. I can get somebody else to sort of help pull or push things or what have you, and that makes it my job easier. But I also think just being curious and creative, if you've got a good relationship with the patient on the other side, ask them to put the camera on the floor and stand in front of it so you can really see those ankles. And I think, you sometimes get a better view of the ankles there than you ever would in your actual practice. And I think there are other opportunities too. I've been teaching residents, along the way, and I find, observing a resident, by hiding myself on the camera is a lot easier than sitting in the corner of a room. So there are other benefits educationally as well, I think, from running telehealth visits. And I think that, I probably have less no-shows and those types of things too. So you don't have to waste space for people who don't show up and double, book them again later, sort of thing.
Tommy, what's the most unusual place a patient's shown up to a video conference with you?
I think it's actually tied between two. I had one who showed up on a boat, so that was kind of interesting. I have a sort of a rule that you need to be in a private space, not out in public, and so on. So I did have someone show up with their daughter at the hair salon once, and I said, we're going to need to reschedule this. It's not going to work. And they said, "Oh no, we'll make our way to a private room." So I think they snuck into some esthetician's room, and we ended up doing the consult through there.
How about you, Brent?
Gosh, I can think of some examples of patients that I thought were normal functioning individuals, and then I connect with them by telehealth, and they're in their pajamas at 11 o'clock in the morning with, a mason jar of wine, in their hand, talking to me. And I think, gosh, I didn't realize that this was an issue in your life. So I think that's probably been one of the more colorful experiences I've had.
That's actually helpful observational data to kind of flavor your consultation. And I think probably everyone's had this, but I've had a few people show up from the bathroom. So I think we've all probably been there. Well, Tommy and Brent, I really appreciate you both taking the time, and I really appreciate your insight. So thanks for coming on the show today.
Thanks for having me.
Thank you very much, Daniel.
If you're interested in more information, you can read the CRA consensus statement on best practices for virtual care in rheumatology on the CRA website. That's it for this episode of Around the Rheum. For questions, comments, and future episode ideas, email us at info@rheum.ca or tag our Twitter account with your question at CRA_SCR_Rheum. Around the Rheum is produced by David McGuffin, Dr. Dax Rumsey, and Kevin Bajnoth. We would like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work. And of course, an extra special thanks to Dr. Brent Ohata and Dr. Tommy Gerschman. Our theme music was composed by Aaron Fontwell. If you enjoyed your time with us, please give us a rating and subscribe so you don't miss future episodes. You can also share this podcast with your colleagues and spread the word on social media. I'm Daniel Ennis. Thanks so much for listening. Until next time.